Foundation Great Lakes region in the Michigan market. I want to welcome you to today's webinar. We still have some families that are joining us, so we're going to give it just a couple of minutes before we get started. If you have any questions or technical difficulties getting started with the webinar, please use the chat function on the right side of your screen to let us know, and we will help you as best as we can. But again, we're going to give it just a few minutes and then we'll get started. And for anyone that's newly joining us, we do have everyone listening today. You are on a listen-only function, so you're not going to be able to be heard by any of the presenters at this time. So again, if you have any questions, please use the chat function on the right side of your screen. For anyone just joining, we're going to give it one more minute, and then we'll go ahead and get started with the webinar. Okay, so once again, I'd like to welcome everyone to today's webinar, Raising a Child with Arthritis, What to Expect, What's New, and Managing Family Dynamics. My name is Kara Dorda. I'm the Program Director for the Arthritis Foundation Great Lakes region in the Michigan market. I will be helping to host the webinar today, along with our featured presenter, Dr. Smriti Mohan. Dr. Mohan is a third-year fellow in the Pediatric Rheumatology program at the University of Michigan C.S. Mott Children's Hospital. We are very excited to have her presenting for us today. Before I turn the presentation over to her, I just want to make mention again that all attendees are currently in a listen-only mode. We will have time for question and answer at the end of her presentation. You can go ahead and type your questions in the chat function and they'll be saved for the end. You can also enter them at the end of the presentation. And we will also turn off the mute function so you'll be able to have conversation at the end of the presentation as well. If you have any technical issues at this time, please go ahead and use that chat function to let us know, and we will address them as best as we can. So at this time, I'm going to go ahead and turn the presentation over to Dr. Mohan. We're very excited again to have her presenting today. Dr. Mohan?
Thank you all very much for having me and for allowing me to speak with you today. So the title of today's discussion is Raising a Child with Arthritis. So what to expect, we're looking at a big picture. What are some of the new things that we're learning, and also managing family dynamics. Whoa. There we go. So just disclosures, I have no conflicts of interest, but I am, as Kara mentioned, a third-year fellow, so I'm in training to be a pediatric rheumatologist, so I am not an expert, and therefore I have the disclaimer that, so this information is really a general overview only, and if you do have any specific questions or concerns, I'll try to answer as much as I can, but specific ones really should be discussed with your primary rheumatologist. So this is the outline for today's webinar. We'll talk very briefly about what is arthritis and just a review of a couple of different types of juvenile arthritis, since that's not the primary focus of today's talk. We'll talk a little bit about the different therapies and more so what we have just learned and what we're learning that came out of the annual rheumatology conference that occurred last week. And then we'll really delve into the what kind of things to expect with juvenile arthritis in terms of managing it. And then a little bit about family dynamics, and then a question and answer at the end. But more so at the end, I'm hoping it can be made a conversation between myself and with all of the different families that are involved. I find that I learn more from my families than perhaps just the reading alone. So in case you are unable to hear anything else and you don't get anything else out of this, these are just my take-home points. So juvenile arthritis, JIA is also another we have the name for what we call it. It's a chronic illness, but recognize that it doesn't necessarily have to define one's life. It's not the be-all, end-all. There's so much more that does go on when just in living life, and JIA can be a part of it. So management of JIA is very much family-centered, and everyone plays an important role. And just recognize and be reassured by the fact that many of the kids with juvenile arthritis grow up to be educated, productive members of society, and do go on to raise families of their own. And our goal, and in terms of medical management and the medical team, is we're all working together to help kids with juvenile arthritis be as healthy and as successful as possible, both in their childhood, but then also in adulthood as well. And the newer biologic medicines and the therapies that are coming out offer really promising results in the medical management of juvenile arthritis, many of which are currently being used, but we're learning more and more about them. So let's get right into it. What is arthritis? By definition, it's inflammation that occurs in the joints themselves. It can be characterized as having warmth, so warm joints. Sometimes they can look red. There can be pain associated with it. You can have swelling, so what we call as effusions, that's going on in the joint themselves. And if it goes on for some period of time, it can actually contribute to loss of function, so really not being able to bend and straighten that joint very well. And I have a picture here, and hopefully you can see my mouse pointing over just the normal joint. You can see the two different aspects of the bone and how they're, the two different bones rather, and how they're separated by this thin film of synovial fluid, which is made really by the synovial membrane and protected by the whole joint capsule. When we think about arthritis, if you ask anybody just in general, they'll think about what we consider as osteoarthritis, this bone on bone, or what we think about old people getting, which that lining really breaks down, and the cartilage that's at the end of the bones really breaks down, and so you get bone on bones rubbing together. Rheumatoid arthritis and even juvenile arthritis, since they're inflammatory arthritis, they're a little bit different. So what happens is you have the cells that make up the immune system and are meant to fight off infections. They get into the joint and really make this angry looking, as you see here. The synovial membrane really thickens. That's where a lot of the inflammation is going on, and can build up the fluid in here that can lead to the swelling that we see. It causes overgrowth as well, and even if it goes on for a long time, can cause a little bit of these erosions and a little bit of destruction even into the bone. So then what is juvenile idiopathic arthritis? By definition, it's a chronic inflammatory arthritis. So it has to go on for a minimum of 6 weeks. Anything less than that we call really acute. Can happen for infection, can happen for trauma, but those short arthritis, they'll get better in a quick time frame. Chronic arthritis won't get better like that. So you'll see it going on for weeks and weeks. And with juvenile arthritis, we don't know what causes it. There's still a lot of research that's trying to figure out exactly what sets it off. We think that there might be something in the environment, maybe an infectious trigger, something that kids are exposed to generally, and certain kids that are more sensitive or susceptible to it, they get triggered. Their immune systems get triggered and cause the arthritis, but we still really don't understand what causes it. Again, by definition, because it's juvenile, it starts before 16 years of age, and it's very important that other causes for the joint inflammation are ruled out. Again, I mentioned infection. One of the more scarier things we think about is cancer, so lymphoma, leukemia. Some of these can present around the same time frame can present similarly, but obviously the treatment can be very different, so it's important to rule other things out. Briefly, the different kinds of juvenile arthritis: oligo-articular, meaning few joints, polyarticular, meaning many joints being affected, and this subset has two different categories. There's rheumatoid factor negative and rheumatoid factor positive, and we'll delve just a little bit into that. There's systemic onset, meaning that the inflammation is going throughout the body. And then there's this larger group called enthesitis-related arthritis. So this includes juvenile ankylosing spondyloarthritis, so inflammation that goes on in the spine, psoriatic arthritis, the one that's associated with the skin rash, and inflammatory bowel disease associated, so kids who have Crohn's disease or ulcerative colitis can also get arthritis. So this is a very broad category and can encompass different things. And then there's also arthritis that is associated with other rheumatic diseases, such as systemic lupus erythematosus or sarcoidosis. So these are a couple of classic pictures from the American College of Rheumatology Image Bank, showing you a couple of kids who have oligoarticular juvenile arthritis, and you can see that it's affecting their knees, especially the little boy on the left-hand side. His left knee looks big, certainly larger than the right side that's not affected. There might be swelling, there might be an effusion going on in there, and what you notice primarily with both of the boys, again more noticeably on the left, is that their left leg is longer than their right leg. And that's because the inflammation causes those areas to grow faster and mature earlier as well. So what you see is that these kids can have one limb that is longer than the other side. And with the boy on the right, if you notice, you might be able to see it subtly, but because that leg is longer, he spends less time on that left side. He may not be able to straighten it fully because it is longer, and so this muscle mass here is a little bit less than what you would see there. So again, by definition, oligoarticular is 4 and below joints involved, so just a few. This happens to be the most common type of juvenile arthritis, and the rates range from 50 to 80% of all kids who have childhood arthritis will have this variant or this type of GIA. And the prevalence is actually pretty common. 1 in 1,000 kids have juvenile arthritis. That's about as common as juvenile diabetes, and we seem to hear a lot more about juvenile diabetes than we do about juvenile arthritis, but this is something that is fairly common. The peak incidence is between 1 and 2 years of age, so we're talking our toddlers who are really mastering the walking, getting into the running stage when they get affected. And there's predominantly more girls than boys who are affected with oligoarticular juvenile arthritis at a ratio of 3 to 1. What do we see on exam? These kids tend to have their arthritis in their lower extremities, so 1 or 2 knees tends to be the most common, although certainly ankles are next in line. You see 89% of cases have just a knee or two, and then ankles, the numbers don't necessarily add up to 100% just because of the variability of presentation. These kids can also have inflammation in their eyes called uveitis. So up to 20%, so 1 in 5 kids can have inflammation in the eyes. It's usually asymptomatic, so by the time we notice that there's something going on with their vision, it may be too late. And it's hard too, if we're talking peak incidence being 1 to 2 years of age, our toddlers are not going to be able to tell us that they're having blurry vision, and they're just getting into that verbal stage, and they may not realize that anything is wrong with their vision. So that's why it's important to have regular ophthalmology screenings. There's a subset of kids with oligo, but also with poly. It doesn't matter actually how many joints are affected. These kids we find more so in girls under the age of 7 years who have a positive anti-nuclear antibody test, are at higher risk for having inflammation in the eyes, and so they actually need more frequent screenings than just kids who have oligoarticular juvenile arthritis who have a negative ANA or who may be a little bit older. What do we tend to see on exam? The same things that we mentioned earlier when we were discussing what arthritis was. So the affected joint can be swollen, it can often feel warm to the touch. with the toddlers, we will often see a painless limp, or our parents may describe a painless limp. These kids can be stiff in the mornings, and that gets better over the course of the day, and then they'll go about their play, their business. So these kids typically don't tend to complain of a lot of pain or tenderness. Again, they may not know the difference, or their verbal skills aren't at the point to be able to tell us that. And the joint tends not to be so red. And importantly, the child who has arthritis is not otherwise ill. These are kids who are still playful, who do go about their routines, except they are limping, or you'll see that the one joint appears larger or appears different than the other. This is in contrast to someone with polyarticular juvenile arthritis, and just a quick glance at this patient's hands, you can clearly tell that they have more than 4 joints involved, clearly all throughout here. All of these are affected, and even a couple of the knuckles. So clearly more than 4 joints. So polyarticular juvenile arthritis is chronic arthritis affecting more than 4 joints. And as I mentioned before, there's 2 types. There's rheumatoid factor negative, which is the majority of the patients in this group, and rheumatoid factor positive kids, and their treatment is different just because their course is a little bit different as well. So the majority of the kids are negative for rheumatoid factor when their labs are checked. And here there are 2 peaks of onset. So we see the toddlers again, 1 to 3 years of age, who can present with several joints being affected. And then there's a group in later childhood and adolescence who can also develop arthritis. We'll discuss that in brief in the next slide. So here again, the knees, the wrists, and the ankles are the most commonly seen, although it is common to have small joint involvement, either of the hands or the feet, and that can occur actually at any point, either early or late in the disease course. It's also important to note that these kids can have jaw involvement, so their temporomandibular joint can be involved, and that's important as well because if the arthritis is not recognized and treated earlier, the jaw doesn't grow in relation to the rest of the face, and so you can actually have a much smaller jaw, and in severe cases it can make it even difficult for normal chewing and eating food, and some can end up having surgery. There's inflammation going on when you have a lot of joints involved, so fatigue can be a common symptom or a common complaint, and this actually can be true even without active joint disease. The problem is fatigue can be very hard to treat, so just something to be aware of. I mentioned that there's 2 peaks of onset for polyarticular arthritis. In the older children and in the adolescents, it's important to consider other rheumatologic disorders. So systemic lupus erythematosus is one of the other rheumatologic disorders that really starts to come out in the teenage, the immediate pre-adolescence, but in the teenage group. So it's important to rule that out. Rheumatoid factor positive kids we consider similar to adults who have rheumatoid arthritis in terms of the pathophysiology, how their inflammation develops and progresses, and therefore we consider it to be a more severe disease, therefore warranting more aggressive treatment. The average age of disease onset is considered to be between 9 and 11 years old. There is very wide variability, so it really 9 to 11 is just an average. These kids will often have symmetric arthritis, so occurring on both sides, hands, feet, wrists, and you can see deformities in the fingers especially. Boutonniere and swan neck are the terms that we have for them, and I'll show you a couple of pictures. So clearly this is not a child with arthritis, but you can see the classic hand deformities when we've had chronic arthritis. So this we call a swan neck deformity. So the swan's head and then the graceful neck, so bent here and then extended here, whereas the boutonniere is the opposite. So the boutonniere has a little hump here as opposed to being elongated. You can see here as well the boutonniere hump right here, the boutonniere hump over here, and this side is extended, whereas the swan neck, you've got the head and then the graceful neck of the swan being extended right there. Moving to systemic onset juvenile arthritis. This is a rash that can be commonly seen in juvenile arthritis in systemic onset form, and what you would expect. So systemic onset juvenile arthritis characterized by daily high fevers that go on for at least 2 weeks. So it's important to note with these high fevers that they're very predictable. So daily, once daily or twice daily, but our families can often tell, oh, I know every afternoon at around this time my child is going to have a fever. And it's accompanied by this rash that you just saw, what we call evanescent. You can have enlargement of the liver, the spleen that goes along with it. You can have inflammation of the lining of the organs, what we call serositis. And these kids may not present with arthritis right away. They may develop it later. Systemic onset juvenile arthritis is different. It's a little bit different in comparison to oligo or poly arthritis in that with the other two you see more girls affected than boys, but with systemic onset arthritis it's really seen equally between girls and boys. The range can be from mild to quite severe and life-threatening as well. And what we've found with research coming out in the past years is that there's elevation of particular inflammation-causing molecules that are called cytokines. So specifically interleukin-1 and interleukin-6, which also abbreviated as IL-1 and IL-6, we call it like a cascade. So there's we call it a cascade storm. They're just suddenly released from the body, and they're actually the ones that cause the fever, which is oftentimes why we see that giving acetaminophen or ibuprofen doesn't help with treating a fever. You have to wait for this cytokine storm kind of to die down, and then the fever will drop. This is important to know because if we know what's causing the inflammation, then those are targets for therapy. So how do we make a diagnosis of juvenile arthritis? By and large, it's a clinical diagnosis. So we rely very much on a good history and a thorough physical exam by people who know what they're looking for to help us make the diagnosis. Labs can play a useful role, like I did mention earlier, and imaging can be helpful as well. So we often think, or we may think in some forms of arthritis that it lasts for a few years and burns out. So this begs the question, why treat at all? The problem is that if we don't treat, chronic inflammation causes changes, permanent changes in the bones, and that can lead to bony deformities, that can lead to limitation in how well a joint can move, and which in turn leads to functional disabilities. And these are the things that we're trying to prevent. We want our kids to be as able-bodied and really functional as possible, and we don't want them to have the limitations. In the lower extremities, you can have leg length discrepancies that result, and when you have initially one side longer than another and then matures earlier and then shorter, that can lead to muscle weakness if the muscle does not get that stimulation that it needs to grow. When you have chronic inflammation going on in a particular joint, it can actually set one up for having early osteoarthritis, which we talked about earlier as the bone bone, just because of that ongoing inflammation. And importantly, for kids who have many joints involved, or who have systemic onset arthritis, they have so much inflammation going on throughout their body that it can actually lead to growth failure. These kids can't grow because any nutrition that they're taking in, any energy that they're taking in is feeding into the inflammation. The inflammation is really sucking up all of that, and it's not allowing for the body to grow. And so these kids may not grow well. And then I'll mention that later too with some of the studies, but that's why it would be important to treat. We want our kids to, again, reach their potential. Early studies, before we really had a lot of good treatments for juvenile arthritis, and in general looking at chronic illnesses, showed that having chronic illness can have a negative impact on the school, on the family, on socialization, and even prospects for adult life, in terms of disability, being able to hold down a job. But what we have found with more recent studies is that, by and large, kids with juvenile arthritis are resilient, and that many of them do go on to complete their education, go through college, are able to have good, successful careers, and are able to raise families of their own. So this is thankfully not so much of an issue, I suppose, but certainly for kids who have active inflammation and adults who have active inflammation and poor health, that poor health leads to poor health-related quality of life. And so we certainly want to improve one's quality of life, and keeping disease under control can help improve one's quality of life. All right, so your child just got a diagnosis of juvenile arthritis. Now what? You may feel like your world is turned upside down. You may feel like you're at this crossroads, you're totally lost, confused, not quite sure who to believe, what to think, where to go. And so that's how you found the Arthritis Foundation and the Juvenile Arthritis Alliance, and why we're having a discussion today, and why we have a good support structure with other families who are going through this or have been through this, and we can all together help each other through manage a child with arthritis and really get control of that arthritis. So something to think about, and this is going to be focused actually as much towards the child, who may not be listening today, but as much towards the child as towards the family. You control the arthritis. It does not control you. These words of wisdom and a lot of what I'll talk about is actually from a patient perspective. So Logan Graham was a young man who came and spoke at the annual meeting last week. He's had arthritis since he was 4. And the insights that he gave, I really took to heart and want to convey that to you today. So in terms of managing arthritis, all right, so we control the arthritis. It doesn't control us. So how do we manage it? We have to acknowledge that it exists. All right, yes, it sucks to have a diagnosis, but it exists. We don't necessarily need to put a label on it, good or bad. We just have to know that it's there. And once we acknowledge that it's there, we have to do what we need to do to control it, and get the control over it and keep it subdued and under control. It's important that we don't let arthritis take over our life. So arthritis is just a sideshow. There is so much more to life than arthritis. So we have to keep it on the sidelines and go about the rest of our life. And what Logan profoundly said last week is that kids with arthritis and families, we have a choice. We have a split-second decision between two choices, and that is we can either be a victim or a master to our arthritis. So what does it mean to have mastery over arthritis? So masters have control over their surroundings, their situations, and that's what we want. So he broke it down into 3 different aspects of it. So you have the medical mastery, which is we know that there's inflammation going on in the body, and we know that the medicines that we use to treat arthritis will help us get control of that inflammation. But the only way that it's going to get control of that inflammation is if we take the medicines as prescribed, which means we have to do it right the first time, taking them as we're supposed to take them and doing them on time. Missing doses sets us up for having disease flares, and it's a lot harder to control the flare than it is to control the disease the first time around and keep it under control. There's physical mastery. So we're talking about something that can limit our joints from moving, and so it's important to exercise. Movement in general will help get over that morning stiffness, keeps our joints lubricated and moving the way that they want to. It pushes out the cells causing inflammation. So it's important to exercise in the right way, in a way that protects our joints, and compensate when needed. So if you're unable to move your wrist, so you'll compensate for that. But if you have muscle weakness on one side, it's important also to give some preferential treatment to that side and build it up so that we can create an equilibrium between both. And then the last point, which I almost feel could be the most important point about mastery, is psychological mastery. And in a quote from Logan, if you don't think you've mastered arthritis, then you haven't mastered it. So feeling like we can control it, that it's something that is within our power, that we're not going to let it victimize us and be left, have life pass us by while we suffer. Having that mastery, having that attitude, that good attitude, right? You can always do more if you've got the attitude to push through. And acknowledging that it is part of your life, good or bad, and just treating it as if it's just any other thing, facetious, but kind of like brushing your teeth, you know? We have teeth, we have to take care of them, otherwise we'll lose our teeth. So you have to brush your teeth. It's not good or bad, it's just we deal with it. It's a routine that we've established. So you could try to consider arthritis that way too. It's there, it's not necessarily good or bad. Yes, you'll have good days and bad days, but it's there, it's just, it's a habit. If you have the habits to keep it under control, it'll make it that much easier. All right, so how do we actually manage then juvenile arthritis, and what goals do we have? We have quite a number of goals, actually. Obviously, the first and foremost is to stop the joint inflammation. And we want to maximize the function. If we stop the inflammation, then we can actually work on maximizing the function and preventing the deformities that come along with it. So maximizing function means using the affected joint, working with our physical therapists and our occupational therapists to regain maybe some lost movement. We also want our kids to achieve normal developmental milestones. They're kids, just like every other child. And they're growing and changing, and we want them to be able to do the things that we see other kids do as well. So 5-year-old joining a baseball team because he wants to, or the 9 or 10-year-old that plays on year-round soccer, or the 12, 13-year-old who stays at home, you know, by themselves, the 16-year-old who gets their driver's license, all those normal developmental milestones, and even things like mental maturity, moving from the concrete thinking into the more abstract thinking that teenagers and really the adolescents develop, which speaks really into the next point of living as normal of a childhood as possible, being able to do all the things as they want to, but also recognizing that the healthy habits that we set up now will help us achieve the good health in adulthood, because we really do need to think about the future. Hopefully our kids won't be having this constantly when they're adults, but the healthier we can have them now, the more tuned up we can have them now, the better their health in adulthood. So management of JA, comprehensive care, absolutely. There are many, many people who need to be involved. First and foremost is the family. It has to be family-centered, because without family support, our kids won't get the care that they need. So starting with the family and then the network beyond it, so coordinated care. So the medical treatment team, the physical therapist, the occupational therapist, the ophthalmologist, even orthopedic surgeons sometimes may need to get involved. The school can play a big role in helping to coordinate this care. Obviously, the medications are a big part of the comprehensive care, the physical therapy, occupational therapy, getting those exercises, working on the range of motion, that's all important. The primary care provider for the well child care, helping to make sure that the growth is there, that the kids are growing, that they're getting adequate nutrition, immunizations, that the immunizations are on time. We worry that getting the flu, for example, may trigger a disease flare, which is why we advocate for the annual influenza vaccine. Psychosocial care is also a big component of comprehensive care. Social services, mental health, making sure that the child is functioning, is interacting with others as they should, interacting with peers, with family members, making sure, looking for depression, things like that. And financial care is a big component of it. Some of our medicines are still quite expensive, and although we're working towards having everyone insured, insurance coverage can still be tricky, and so it's important to make sure that we're addressing all of those. And then watching our kids over time and having that continuity to make sure that we're treating as we should, and if things aren't in treatment, that we act quickly to get the disease under control again so that our kids go back to doing what they need to be doing. So the parents' role. The parents have a huge role in this. So first and foremost, you have to understand your diagnosis, or understand their diagnosis rather, and you have to help your child understand their diagnosis. Obviously, to what their age is, what a 2-year-old understands is very different from what a 12-year-old understands. But it's not just one parent who should know what's going on and understand what's going on. All the parents, whether they're step-parents or other primary caregivers, having everybody involved and on the same page is important. And the parents, one of your main roles is to help your kids take their medicines as prescribed, emphasizing, of course, that missing doses just makes the arthritis rear its head and makes it say, hey, I'm here, don't forget about me. We know that the arthritis is there. We just want to keep it subdued and keep it out of the way, and keeping it on the sideline. So it's hard to give kids their medicines, and it can be easy to relent and say, well, one dose won't hurt, but we don't know that it won't. And if it makes it easier for the disease to flare, we certainly don't want that. We want what's best for our kids, and we think about the long term. And we as parents actually have the luxury of thinking about long term, since kids can't necessarily think about the long term for themselves. They just don't have the development to think about things like that. Parents can also help improve the functioning, the range of motion, doing PT and OT exercises with them. They can be boring, they can be unpleasant to do them, but really interacting with them and being involved in that way can make the time pass quicker and can make it easier for the kids to do their home exercises. Organizing the unpleasant or the annoying things about treatment around more enjoyable activities may be one concrete example of helping manage the arthritis, and helping the kids manage the arthritis. So giving them a methotrexate shot during a favorite TV show is what some of my families will often do. So that way the kids are distracted and they get their shots, so they get their treatment, but it's not getting in the way because they're doing something that they enjoy doing. One suggestion that I'd also heard was, while watching your favorite TV show, or even like during commercial breaks, doing the physical therapy exercises, doing the home exercises, so incorporating that into a routine that you're already doing so that it's not something else, another thing to tack on, because our days are really busy and our evenings go by really quickly. It's hard to fit everything in, so trying to multitask can go a long way to fitting things in. It's also important for the parents to make your child independent. Our role as parents is to make our children as successful adults. They'll eventually leave us, so we have to teach them how to take care of themselves. We want them to be dependent on us. It's important that they go off into the world and make their mark. So little things like letting them fill their pill boxes when they're younger, helping out with that aspect. Letting them take their medications when they're older. Certainly at a stage they'll need to be supervised, but giving them some of that independence can really go a long way to making them independent. Letting them talk to their doctor alone, certainly when they're as older adolescents. And this specifically may allow for them to develop that relationship with their physician, which they'll need to do when they become an adult. When they go on to see an adult rheumatologist, it's a relationship between them and their rheumatologist. It's not the same family-centered care that happens on the pediatric side. And so giving them an opportunity, or little bits of opportunities earlier on, can help to start that relationship, and allows for their questions and concerns to be freely asked. They may feel embarrassed to ask something in front of their parents. So even just a little, 5-10 minutes during a doctor's visit to establish that relationship alone can be fruitful. And then also involve the siblings. They need attention too, so that they don't feel neglected. So the parents, you do have to focus on your child with arthritis, but you also have to focus on the rest of the family as well. and that's hard. That can be very challenging. The child's role is to take their medicines and do their therapy so that they can keep their arthritis under control, and obviously taking on more ownership and more responsibility as they get older. It's important for our kids to go to school every day. It's hard. When kids are really stiff in the mornings, it can be hard to go to school when they're not feeling well. But the socialization that school provides and the other distractions and the learning really that school provides can't be met in the same way as it can't be met in the same way at home as it can at school. So we really advocate for our kids to go to school without missing a day. Obviously there are extenuating circumstances. All kids have talents. Kids with arthritis have talents, no different from kids who have other illnesses or healthy kids altogether. So it's all a matter of finding and exploiting your talents and using that. And it's important to realize that kids are adaptable, and we should treat them as if they're adaptable and that they can change and that they can grow and work with that. Certainly the child with arthritis has a lot of growing to do mentally, emotionally, and physically in this context of having a chronic illness. But with that growing, there's an opportunity too, specifically with transitioning, taking on some of that responsibility. Some of the kids with arthritis, they may mature faster than healthy kids because they have to face things that do certain things that healthy kids don't necessarily think about. And so learning about that early and taking on more responsibility, relearning about their arthritis as needed. Again, what a 12-year-old or an 18-year-old understands about arthritis is very different from what a toddler or an early elementary school child understands. So it's important for kids to start thinking and preparing for the future early. So what skills do you need to be successful as an adult? A lot of the same skills, actually, that you need to be successful to master your arthritis. So organization, taking meds, have pill boxes, check. Got that taken care of. Responsibility, yeah, you need to be responsible to be a successful adult. Kids are going to have the maturity to take their medicines as prescribed, check. They can already check that off. Compassion, empathy, kids with arthritis, you're dealing with a chronic illness already, so you can relate to others who may have illnesses or just in general have compassion and empathy and relate in a way that people who aren't faced in similar situations may not be able to relate to. Knowledge. So this goes back to the going to school. You have to be able to attend school and suck in all of that knowledge. Kids are sponges. It's important to get all of that so that they can go on to college and have that real job and be productive members of society. What about siblings? So I briefly mentioned siblings earlier. Siblings often feel left out. Healthy siblings may feel guilt, guilt that they caused the child with arthritis to have their arthritis. They may feel anger towards the child with arthritis. They may feel shame, resentment. They may feel neglected. The child with arthritis obviously has more doctor's appointments, having to have the reminders about the medicines and doing the home exercises, the PT visits, and the healthy siblings may feel neglected. So a gamut of feelings that siblings feel and that are often not acknowledged. And so they do feel left out. And this can show up in a myriad of different ways. Siblings can have changes in appetite, they can have changes in sleep, mood changes, depression, for example, anger, acting out behaviors. They may not be able to focus as well in school, and so they can have decreased school performance, so their grades might start slipping. Younger children may actually have regression, so things that they've learned, they're no longer doing them, they're regressing to younger stages. And conversely, there may be attempts to be the perfect child, the child that doesn't need the attention, that is self-sufficient, trying to compensate for the child that may have more needs. All right, so now you're telling me that I've already got one sick kid and I have to deal with another? Well, yes, but here open communication really helps. So acknowledging to the siblings that, okay, yes, so you have a sister or brother who has arthritis. and that it can be tough on the healthy sibling, and just talking to them about their feelings, validating them, and acknowledging that they can have good feelings, bad feelings, you know, the anger, the resentment, and everything in between, and having that open air and letting them know that it's okay, that they don't have to hide, and that they're certainly not left out as well. With some kids, it may be helpful to let their teachers and counselors know that they have a sib in the family who's ill, just so that the teachers and counselors can know to look out for behavioral changes, the slipping grades, etc. It's also important to maintain as much of the family routine as possible, and treating all of the kids equally, so that the child with arthritis doesn't get special treatment, not having to do chores, for example. Having all the kids contribute equally to the family, all the kids doing chores, but of course what is within their abilities to do. So factoring in what abilities the child with arthritis has. Again, it's important to give some attention to the healthy siblings. One-on-one time would be very important. So examples that I've seen and have been recommended, so if two parents are coming with the child with arthritis, so one parent can go off with the siblings that are coming in and giving them that healthy, that just one-on-one time with the healthy sibling, or letting the healthy sibling stay up half an hour later, for example, so that they get that one-on-one time in the evenings when the child with arthritis goes to bed earlier, or special outings, things like that. The siblings do have a role to play for with a child who has arthritis. It's important to include the siblings. They can actually be a really great source of support for the child who has arthritis in different ways. So physical, carrying school books, for example, doing the home PTO2, joining in on those exercises that I mentioned that parents can do. The kids can do it too. All the kids can get together and do the exercises. Movement is always a good thing. Our bodies are meant to be active and to be moving at all times. So a little bit of more stretching exercises can even help the healthy sibling. Certainly emotional support is a huge thing. Being there when the child with arthritis needs them, whether it's at school, support, at school, just being there as a shoulder to lean on, to cry on, someone to confide in, being there at home, and can even actually help out on the mental aspect, the medical side of it. So this can be reminders for taking the medicines, or helping them to fill their pill boxes. Or Logan actually mentioned, which I thought was quite interesting, that his older sister, who at the time was 9, was taught how to give him eye drops so that the parents could leave on a date by themselves and leave Logan at home with his sister and babysitter, but then made him and his sister more independent, because if she's able to administer the medicines, that gives a lot of freedom. It's not just the parents who are tied to giving the medicine. So even something like that may be a possibility, obviously within the realm of safety. Attending appointments can be helpful for siblings as well, so that they know they can meet the doctor and know that it's not scary, because they may have fears about what goes on at the doctor's office or in the hospital as well. The medical team can be comprised of multiple people, so including the pediatric rheumatologist, the nurse, the social worker, obviously the physical and occupational therapist, at times ophthalmology and orthopedic surgery too. So the medical team's role is to determine what the best medicines and therapies are to get the arthritis under control and to keep it under control. They can also be very good advocates for needs at school, so things like an individualized education plan or 504 plans. They can provide accommodations like having extra books, so that the kids aren't having to carry books between home and school. Extra test taking time, even little things like avoiding sun exposure for kids who are on meds that are sensitive to the light, or who have diseases that flare with the light. That goes in a little bit into the pharmacological treatment. So your medical team is determining what medicines are the most helpful. So what are the different categories? non-steroidal anti-inflammatory drugs, so NSAIDs. This is a family that includes ibuprofen. The brand names are Advil, Motrin, or naproxen. Brand names will even naproxen, things like indomethacin, even Selenac. There's a lot in this category. They manage that. So NSAIDs are often used in treating juvenile arthritis. The next step-up category is disease-modifying antirheumatic drugs, or DMARDs, and here it's subdivided into the non-biologics. So when we're thinking of this category, we're thinking about methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. Just a note on hydroxychloroquine, it's an adjunct medicine initially developed as an anti-malarial, but they found that it was actually really good for treating arthritis. It doesn't necessarily work so well on its own, but when it's used with other medicines, whether it's an NSAID or any of the DMARDs, it boosts the control of arthritis. We never really understood why it helped, and there's some new information and new research coming out. It's coming out in the literature, and some of what was presented at the annual meeting last week that suggests that hydroxychloroquine actually has what we call immunomodulatory effects. So it actually modifies and modulates the immune system to really bring down that inflammation, and even actually has some crossover effects. Some of the new research suggests that it can be really good to lower cholesterol. It can actually be helped in the management of diabetes. It can bring down the blood sugar. So really, the new stuff that's coming out is really exciting. So this is a medicine that is used quite a bit as well. Next category, glucocorticoids, what we generally refer to as steroids. This can be meds that we take by mouth, but also joint injections, which are often done. And then the DMARDs, there's the biologic category. So these biologics are the newest therapies, and they're really targeted at different inflammation-causing molecules. Your rheumatologist, and all rheumatologists, honestly, have their own way of treating, and some are more conservative than others. Some will do a step-up approach, starting from the top of the list and adding on. Some will start off more aggressive and really want to throw kind of the kitchen sink because they really want to get quick control of the arthritis, and then they'll taper back on some of the medicines. So there's really no standardized approach because we don't know what works yet to really get control. So everyone has their own style of doing things. And so if you have certain stylistic questions, obviously that's a discussion between you and your rheumatologist. All right, so a bit more about biologics. So like I said, these are different targets to the immune system. Targets that, specifically that cause the inflammation. So tumor necrosis factor, or TNF-alpha inhibitors, were one of the first biologic drugs that were produced. And these are really good to treat joint inflammation, so the actual arthritis. And they're actually especially good for the psoriasis subtype because you can get control of the arthritis as well as the psoriasis. And then I mentioned with systemic onset arthritis that you have IL-1 and IL-6 as being the two major cytokines, these two major inflammation-causing molecules. And so the medicines to target that are IL-1 blockers and IL-6 blockers. And so IL-1 blockers or inhibitors are especially good for systemic onset JA, especially when you're targeting the systemic form of it, so the fevers, the rash, as opposed to the arthritis form. So when we think of IL-1 inhibitors, we think primarily of anakinra. That's one that is used very much. And these are daily injections, which are not necessarily pleasant. There are other IL-1 inhibitors, rilonacept and canakinumab. They work slightly differently. So fresh from the ACR, these are definitely in treatment. People are using them, but what we're showing now is that the clinical trials for FDA approval and really to see do they work or do they not, what's the evidence for them, they really show good promise for treatment. IL-6 blockers, tocilizumab, is a primary one, and this has already been FDA approved for the use in systemic onset JIA. What is fresh from the ACR is that this is promising medicine for both the arthritis aspect of systemic onset JIA and the fever and rash and more of the systemic signs for systemic onset JIA. And then there's certainly other ones. This is not a comprehensive list by any means. So abatacept blocks T cells, which are a main portion of fighting off inflammation. And that has been approved for treatment of polyarticular juvenile idiopathic arthritis. rituximab is a medicine that blocks the B cells, which is what forms your memory cell. That gives you the memory of immunity, which is why we also treat our kids for quite a long time, because the immune system does have a long memory, and so we want the immune system to forget that it was ever attacking itself, so that when we eventually come off of the medicines, it doesn't remember it was doing that and won't cause a disease later. So an update from the annual rheumatology meeting, the American College of Rheumatology, which is actually an international meeting. So systemic onset JA was the main focus, and updating the different trials was the main focus this year as far as pediatric rheumatology was concerned. So the canakinumab trial, so this is an IL-1 blocker, and this medicine is in phase 3 of drug trials. Showed that it was effective against placebo, and specifically actually the kids who were on canakinumab actually had a successful steroid taper. So most of these kids who were on it were also on methotrexate and were also on prednisone of some fashion. And we don't like prednisone. It works great short-term for getting rid of inflammation, but it comes with some nasty side effects. And so if we can get our kids off of prednisone, that is what we would like to do. And so canakinumab allowed for these kids to come off of steroids faster than earlier. So the TENDER study looked specifically at tocilizumab. This is a little bit different. So they were looking at kids who had growth failure and trying to see if treating with tocilizumab to treat that extent, the severe extent of the inflammation going on in the bodies, allowed them to catch up on some of that growth. And it showed that it did, which is exciting because, as I mentioned, growth failure is a problem and a concern of ours if there's untreated chronic arthritis. And so to know that our treatments can allow for this catch-up growth and allow these kids to get closer to their potential is exciting. The rapport study looked at rilonacept, which is an IL-1 blocker, and this is a phase 2 trial. This just completed enrollment, and so we'll be seeing in the next couple of years what happens with that. But the preliminary studies were quite exciting. We're promising that rilonacept also works well to control systemic onset juvenile arthritis. The CHERISH study is, again, a tocilizumab trial. This is a phase 3 drug trial, again, versus placebo. And what really came out of this is that tocilizumab may be a good choice if you've got both the active systemic features, so again, fever and rash is what we primarily think of, as well as the synovitis, as well as the inflammation in the joints. Like I mentioned, anakinra doesn't do so much for the joints, but here tocilizumab actually might be a good drug to consider when you've got a lot of arthritis for kids who have systemic onset JA. Like I mentioned, the anakinra. And what we do already know from systemic onset JA treatments is that the TNF blockers, for whatever reason, they just don't really work very well. So these other medicines, again, which are being used by some practitioners, but we're learning more from these trials, these other medicines hold promise. Here I'd like to mention the Childhood Arthritis and Rheumatology Research Alliance, otherwise known as CARA, and specifically the CARANet registry. So this is a United States and Canada-based initiative. So it's a group of participating pediatric rheumatology centers. And the goal of CARA is to develop evidence-based therapies so that we can standardize JA care. Like I mentioned, you ask 10 rheumatologists how to treat something, and they'll give you 11, 12, sometimes more different answers, just because there is such wide variability. It would be great if we could have these guidelines that say, okay, your child was diagnosed with oligoarticular of the knee at this age. What we have found best, what the evidence shows is that you start this, this, and this, and do this, and you treat for this period of time, and this will work in most kids, so that the kids really get standardized care that we know that works, so it can eliminate some of the trial and error that we sometimes see, that kids try one medicine and it doesn't necessarily work and we have to move to another. But again, that also varies. The biology is different too. Each kid is different. So a few resources. The Arthritis Foundation and that subset, the Juvenile Arthritis Alliance, has a lot of resources and a lot of information. CARA that I mentioned, so that's CARA group, and for families who are interested, Friends of CARA also works with Kara for us to be able to develop these the evidence for the treatments, why we treat the way we do. Certainly the American College of Rheumatology has a lot of resources as well. So just to sum up, really just to emphasize, arthritis does not define you. You define the arthritis in your life. And care is very, very much centered around the family. That support is extremely important. Otherwise, we would not be successful. The child with juvenile arthritis takes more responsibility as they grow up. Transition is a process that starts early, because what we're trying to do is we're trying to make them become successful adults, because we expect them to grow up well into adulthood, and we want them to be as healthy as they can possibly be. And siblings do feel left out, so it's very important to get them involved, attending appointments, helping out with some of the home exercises, for example, being that social, emotional support. And the newer therapies are very promising. We've been using biologics to some extent, and I anticipate that we'll probably be using it to a larger extent as more information comes out. And what's especially exciting is to think that we're going to be developing these standards of care that'll help us really be able to manage the arthritis better, and to get them controlled faster and better, and to keep our kids healthier. These were some of the references from the study, and of course I would not be able to end our talk without acknowledgments. Dr. Adams, Dr. Haftel, Dr. Liebschlager, and our nurse Ann Jackson at the University of Michigan, and certainly our university, for all the support that they've provided me, for the Arthritis Foundation and the Juvenile Arthritis Alliance for allowing me to speak today, to Logan, and to everyone from the annual meeting from whom I've learned so much, to Kara, of which we're a member network, but also for their efforts to help children with arthritis. And of course, none of this would have been possible without my patients and their families, and everything that I've learned from them. To them, I'm truly indebted. So I would like to thank you all for your time and for joining in on this discussion, and open up the floor to any questions and to a conversation.
Before we go ahead and take questions for Dr. Mohan, I do want to announce that after the question and answer period, we will have some announcements and information from the Arthritis Foundation, so please stay tuned for that information. But at this time, we're going to go ahead and unmute everybody. We'll try and get to all the screen to ask a question that we'll direct to Dr. Mohan, or you can ask verbally. So go ahead and please type your questions or
muted.
Do we have a question coming in?
Anybody right there? Serafino's on the line, Jim.
We can hear you. Go ahead and ask your question.
Remember what we need to do with these Spin Master.
Okay, let's wait for Burchak, and then we'll get started.
I know we called.
Burchak is here.
There were some questions that came in via the question box, so I didn't know if Dr. Mohan wanted to answer those.
Oh, sure. I heard some other people talking earlier. I just couldn't hear it. All right, let me see if I can.
You know what, we'll go ahead and take a minute while Dr. Mohan's reviewing the questions for answer. I'll go ahead, if Dr. Mohan, you can share the screen with me. I'll go ahead and put up our presentation from the foundation, and then we'll come back to the questions in just a minute.
Sure. All right. So
from the Arthritis Foundation, again, we want to thank Dr. Mohan for all of her hard work on the presentation today, and for sharing all of the wonderful information and resources that she presented. I also want to make everyone aware that within the Arthritis Foundation Great Lakes region, we have several contacts for you for any questions or JA resources. I've listed each of the staff persons responsible for JA in the respective markets. Again, you can contact any of the emails that you currently have, or toll-free phone numbers, market phone numbers, or even the number listed on the bottom of the screen to reach any one of these staff persons. They will serve as your local resources that you can go to. And some of the resources available from the Arthritis Foundation include our educational brochures, such as Arthritis in Children, or When Your Student Has Arthritis. Those are available for families. So please feel free to contact us if you'd like additional information. We have a great packet regarding 504 plans. If you're trying to start a plan with your child's school, please contact us. We'll send that out to you. Some new items coming up in 2013 that we're working on, and they may be active in some of our current markets, but a parent-to-parent network. If you're looking for support or to reach another parent of a child with a similar diagnosis or age, your local market staff person will be able to help in making that connection possible. And we can also work on doing that for you for your child or teen as well. This past year, the Arthritis Foundation in the Great Lakes region, we've rolled out the SAC Backpack Program. SAC stands for Supporting Arthritis Kids. It's a wonderful program. We have lots of great resources included in the backpacks. If you haven't received one yet, please feel free to contact your market staff person and we will talk to you about getting one out to you. We also have wonderful camps and family days that are organized by a majority of our markets each year and available to our families throughout the Great Lakes region. Again, so please contact us for more information about that. Coming in 2013, we also hope to have available a juvenile arthritis family newsletter. And existing resources also include a unique website for kids, tweens, and teens, the Kids Get Arthritis 2 website, available through arthritis.today.org. For parents, there's also a great informational section on the Arthritis Foundation website itself. You'll need to click on the Disease Center for Juvenile Arthritis, and it will have all kinds of information available. And upcoming in 2013 is our annual Juvenile Arthritis Conference. This year it's going to be hosted in Anaheim, California. If you can take advantage of any scholarship opportunities that we may have available or even attend on your own, it is one of the best things that you can do. You have an opportunity to hear excellent speakers from across the United States and network with other families and children with juvenile arthritis. We thank you for participating today. We thank you for Dr. Mohan for all of the hard work you put into your presentation. We ask that when you receive a survey in the next few days that you take just a couple of minutes and fill it out and let us know what you thought of the presentation today. At this time, we're going to turn it back over to Dr. Mohan, and she will go ahead and answer some of the typed questions we've gotten or some of the verbal questions coming in.
Okay. I'm in the process of answering one of the questions on the ophthalmologist, so why don't I just go ahead and verbally answer that instead of finishing the typing. So the question being, how does the ophthalmologist evaluate for uveitis? Is there any research or evidence on fish oil promoting healthy eye tissue or preventing uveitis or bacterial infections in the eyes? If so, do I have any articles to share? So the ophthalmologist specifically does a slit lamp exam, which is why it has to be an ophthalmologist and not an optometrist who has to evaluate. And so what they look for are cells, the same cells that cause inflammation of the joints. They're looking for those cells floating in the back of the eyes that could be indication that there's inflammation in the eyes. So I don't know of specific evidence for fish oil specifically for healthy eyes, but fish oil can certainly help with overall nutrition and health status with, in general, with juvenile arthritis. And I'm not certain specifically with bacterial infections, although I'm happy to look into that and get back to you if there is anything specific. But I actually have not heard anything specific about fish oil to keep bacterial infections at bay or to prevent uveitis. Let me see if I can find the other question. So how are you treating kids with JIA and the TMJ? My daughter has had steroid injections into the TMJ without success. She has continued inflammation and progressive joint damage. So steroid injections are certainly one thing that I've heard of. I know that there are some pediatric rheumatologists, not just actually in the United States, but I think actually even internationally, who are doing things like infliximab injections into the TMJ. And so you could look into that. I certainly have not done that myself, and so I can't comment on that. But if steroid injections haven't worked, that may be something to consider. I do know that there are some pediatric rheumatologists who have tried doing infliximab injections, which is a TNF blocker, so it's a biologic medication, and it may be able to help, but something to consider. And Kara, you might need to help me out. I'm not sure if there's other questions that I'm missing that I'm not able to see.
If anyone wants to ask a verbal question, if you could raise the hand tool that is right by your name. And then I can unmute you so we don't get too much feedback. I don't see any hands being raised. Oh, here, one came in. I'll send it over to you, Dr. Mohan.
Okay.
Did it come over?
I didn't hear anything.
The question is, my son has MCTD. He is 16. Do you know of any resources for parents with MCTD kids or for kids/teens with MCTD?
So I have a couple of kids with MCTD, and I don't know of specific organizations, but I would think that the American College of Rheumatology may have links to organizations that may be working with kids who have MCTD. Again, I can look into that and get back to you, but I don't know of any specific groups. Even for things like lupus, for example, we used to have a lupus group for our kids who had lupus, but at that time it had been very difficult to coordinate, and you know, everyone is busy, kids are busy, families are busy, so I know we had tried to do a local organization, so I don't know if there are other families who have started to do anything like that.
And the final question was about the SAC backpack program. Someone attending lives in Illinois. And Kara, I'm not sure if you want to address that, if other regions have the SAC backpack program. I know you can go on arthritis.org and search under Illinois to find contact information for that office.
Certainly. If that family would like to go ahead and email me, I can try and put you directly in contact with the staff member in your respective market. I know some of the other regions do have the SAC backpack program available. If they currently don't, we would be more than happy to go ahead and send the family out a backpack.
That was the last one I got in.
Are there any more questions? Again, you can raise your hand by your name in the attendance box, or you can go ahead and type a chat question.
I didn't see any coming in.
I apologize. People had trouble hearing me. I hope it wasn't too much of a problem.
For anyone who did have difficulty hearing during the presentation, we will make the presentation available on demand on our website, so stay tuned within the next few weeks and you'll see that up there. Again, we'll have an evaluation that's coming around. Please provide us with all feedback. We truly appreciate it, and it's how we can develop topics for our next Kids Get Arthritis 2 presentation. If you have any questions, again, please contact a local staff member, or you can send me an email and we'll get you in touch with the person who handles your market. Thank you again for attending today. Thank you, Dr.